So Dr. Elias is Associate Professor here at MUSC, and we're very pleased to have her share some information about scleroderma and GI issues. This was one of the main areas of interest in the last year's evaluation. I know it's a constant struggle for all of us, and there are no easy answers, but the more we understand about it, the better we can manage or advocate for ourselves. So thank you so much, Dr. Elias.
It's usually hard to compete at the time slot before lunch, but there were a lot of snacks out there I saw. So hopefully you've filled up. We'll spend the next 40 minutes or so just going through the manifestations of the GI effects of scleroderma, and I'm sure many of you are somewhat versed in it, and I'll leave some time for questions, and then I'll be here for lunch. If you have any questions, I'm happy to try and answer them to the best of my abilities. I'm just going to first start off with just two case scenarios to give an idea of the breadth of the patients that we see in our clinics. We'll start off with a 75-year-old woman who presented in my clinic for evaluation of chronic diarrhea. She had a medical history significant for scleroderma over the last 10 years. She had also a history of reflux, which she was controlled on therapy. She's had 1 year of symptoms, including bloating and diarrhea. All of her endoscopic exams were normal, and her stool studies were normal as well. So that leads us to the question, what do we do next, or what do we think that her symptoms are caused by? On the flip side, we have a 39-year-old female who presented with heartburn and difficulty swallowing, or what we refer to as dysphagia. She had ongoing workup. GI and rheumatology were occurring at the same time. She was also having joint pain and joint swelling. And EGD at that time showed severe esophagitis, and we'll see some images of that in a little bit. And so the question is there anything else from a GI standpoint do we need to do, or do we chalk this up to uncontrolled reflux and let her go on her way? We'll keep referring back to those two case scenarios as we go through this talk this morning, but my objectives for the next half hour or so are to understand the prevalence of GI involvement in scleroderma, to review the presentation and management associated with the disorder involving the esophagus, the stomach, the small bowel, and the colon and anal rectum, and then also to just offer some exposure to the current treatment modalities that we have for each of these specific organs. So this is probably information that you're very well aware of. About 240 people per million are affected. 50,000 Americans are affected with scleroderma, 2 to 3 times more likely to be seen in women. And the age in which the patients usually present are somewhere around their 40s to 60s, but we see them, some older than that, and then of course patients who are younger than that. And at this point, there are many speculations and hypotheses, but the actual cause is unknown, which makes it very challenging to come up with treatment modalities. So a very busy slide that our pathophysiologists love. But basically, in the GI tract, what we know is that there is some sort of initiation of an inflammatory cascade, and that damage occurs at the endothelial level, so at the level of the blood vessels. At this time, inflammation ensues, and a variety of cells come into play. There is vascular damage, a tissue ischemia, if you will, so deprivation of the tissues in the GI tract of oxygen. The reperfusion of that tissue occurs, but with that also comes a scarring process or fibrosis. This happens anywhere in the GI tract, and this constant cycle of injury is really what leads to eventual damage to the nerve cells of the GI tract, and also stiffening of the GI tract, if you will. So we see this affecting all sorts of areas, basically from mouth to rectum. We know that 90% of patients with scleroderma have some sort of GI involvement. We know that in 10% of cases, similar to that 39-year-old patient I initially presented, that it can be one of the first manifestations of the disease. We also know that in patients who have severe disease, and this is mainly with malnutrition, 8% will progress to severe disease, and there's an increased association of morbidity and mortality. So our job, although it's we cannot stop the process. We can identify those patients at risk earlier and intervene and hopefully change that course. As I had mentioned, can affect any site. We know that it occurs in limited and diffuse scleroderma. It can occur at any time during the disease. So whether you have diagnosed scleroderma for 1 year versus 15 years, the symptoms related to the GI tract can happen at any time. Patients can also be very asymptomatic. So the involvement of a variety of organs is usually quite indolent in the beginning, and until the scarring process occurs, we start to see some of the manifestations as symptom presentation. And we also know that GI involvement affects quality of life scores significantly. This is a slew of symptoms that patients often report, and I just want to point your attention to dysphagia, or what we call difficulty swallowing. It's probably the most common thing that we see in patients, and that along with reflux, and that's usually the cause of it. We'll start off briefly with the oral cavity, a little bit out of my realm. Usually my exam and interventions with patients starts kind of at the what we refer to as the upper esophageal sphincter. So, but these are some of the changes that we can see in the oral cavity. So patients can present with decreased mouth opening, impaired tongue movement, dry mouth. And some of my dental colleagues, when I have patients who come in who have seen a dentist prior, will let me know that they've been given special toothpaste, they have special mouthwashes, frequent water sips, as well as artificial saliva to keep the mouth lubricated. Avoidance of certain medications, and this is key for GI because we use a number of these medicines to help with other parts of the GI tract. So these are medicines that actually dry up salivary glands, so we want to try and avoid these in our patients with scleroderma. And then mouth stretches and connective tissue massage, which when they happen early enough can actually really have a significant impact on patient quality of life. So the esophagus, which is my niche and my area of greatest interest, is the most common organ involved in the GI tract. It occurs in greater than 75% of patients where we see organ involvement. Muscle is replaced by connective tissue here, and this is really smooth muscle, and it is preferentially the lower 2/3 of the esophagus. So the esophagus, although it looks like a very simple structure, just a tube that's connecting your mouth to your stomach, it actually has a very complex function in a relatively short period of time. So within the time that food enters your mouth to the time that it goes into your stomach, that is about a 4 to 5 second process. So the signals that happen are very quick, and the response of the esophagus has to be very sophisticated. What happens is as food enters the back of the mouth, or what we refer to as the oropharynx, the upper esophageal sphincter, which I don't know if I have a pointer. Yeah. So the upper esophageal sphincter, there we go, right here opens, allowing that bolus to pass, and thereafter is a very coordinated movement that the esophagus has to quickly basically make happen. And what happens is there has to be a squeeze, release, and that happens all the way down until it gets to the lower esophageal sphincter. Now, interestingly, the way the esophagus works is this part right here, the first third of the esophagus is skeletal muscle. The bottom 2/3 is smooth muscle. So in scleroderma patients, this part is absolutely intact. And where we see the problems start to occur is actually 2/3 of the way down, all the way down into the lower esophageal sphincter. This image that I have here, interestingly, is a patient of mine who had very, very severe esophagitis, and it was fascinating, the demarcation of where her normal esophagus ended and where her severe esophagitis began. So this is the upper, that's a picture of her upper esophagus, the skeletal muscle, and I'll show you some images of her lower esophagus shortly. And so what happens in scleroderma is the bottom sphincter has low to absent pressure. That means it's basically open. The 2/3 of the esophagus that occupy the esophageal body have weak to absent peristalsis. So peristalsis is a fancy way for us to say the squeeze pressure. And so there is no squeeze, and then you have a wide open flap. So as you can imagine, and the top part is working fine. So a lot of times patients will say, I don't have a problem here, but I just feel it getting stuck right here. Or they'll say, I really feel discomfort down here. The esophagus is fascinating because sometimes discomfort that happens down below is actually referred to up top. So, it's hard for us to tease out, but this is really where the issue starts. So this is a manometry image, fancy, colorful, high-resolution manometry, which is actually the gold standard now for us in diagnosing patients with what we refer to as a scleroderma-like esophagus. You'll see a normal manometry study here. If you see this area, red, the colors basically measure pressure. So hot colors, or as my kids would say, warm colors here, are high pressure zones. So this is the upper esophageal sphincter. A lot of pressure here to stay closed, mainly so that you're not constantly swallowing, allows you to breathe, allows for you to have things in your mouth, and the esophagus doesn't always open to receive those. You're chewing gum or eating anything. But you see an opening, you see a break here, and this is the swallow. So this break allows for whatever it is that you swallowed to move all the way down. And the green here is the marker of esophageal pressure, so that muscle kind of squeezing all the way down. In a normal patient, as you can see, this kind of diagonal movement is exactly what we talked about, coordinated movement from the top to the middle to the bottom, and this is against a y-axis of time, if you will. So within 3 seconds, you swallow, and it moves all the way down. You see an opening here of the lower esophageal sphincter, and you see the pressure kind of end there. In scleroderma patients, so the UES is intact, looks totally fine. The striated skeletal muscle looks totally fine, and then you have total loss of that squeeze. And on the bottom, you don't have any sort of high pressure zone here. So you anticipate that the lower esophageal sphincter is a valve that's just staying open, if you will. So how does that manifest as far as when we try to image the esophagus? This is an endoscopic ultrasound, which allows us to really evaluate the different wall layers of the esophagus. What you can see usually is that there are 4 layers to the esophagus. So a mucosal layer, a submucosal layer, we usually have a muscle layer, and then we have serosa. What you see here is loss of delineation of all those layers, and you see a very thick band, which is the fibrosis and the collagen deposition that occurs in the esophagus. How that translates to its effects is it prevents the muscle from actually squeezing. So, as you can imagine, a wide open valve and a lack of movement here really predisposes this part of the esophagus to a lot of injury. The lower esophageal sphincter is made to relax 48 times in a 24-hour period. That's what we allow. We say if a patient is having a normal reflux study, we're allowing them to have 48 reflux episodes. Everybody has a little bit of reflux, mainly because this sphincter, as you can imagine, has to open. It has to open to allow you to swallow. It has to open to allow you to belch. So that's a normal function. So refluxing is actually not abnormal. When it becomes abnormal is if it's happening more than 48 times in a 24-hour period, or if you're having an excessive amount of refluxate coming into the esophagus. So if you picture your stomach like this when you're standing up, imagine what happens when you lie down. And that valve is not closing. You've now lost gravity in your favor, and the stuff that you have in your stomach is kind of just slushing around in your esophagus. So the issues that patients have when they have these, when they have a weakened lower esophageal sphincter and lack of mobility here is they'll have symptoms of heartburn, regurgitation, so it's very easy for things to come up. They'll have dysphagia or difficulty swallowing, odynophagia, a fancy word for painful swallowing, which we sometimes see with esophagitis, cough or hoarseness. And this is how patients present to us in our clinics. This is a still image of a barium study, and what you notice here is usually in a barium study, the barium that patients drink should move all the way down into the esophagus, and what you see here is it's just staying there. It's moving into the stomach because the valve is open, but it takes a long time to have that barium fall. We rely heavily on gravity for that to happen. So when we have patients who have long-standing gastroesophageal reflux disease, or what we call GERD, we can see strictures, ulcers, Barrett's esophagus, sometimes malignancy, and sometimes outpouchings in the esophagus because, or what we call diverticula, because the esophagus just kind of gets used to having a lot of stuff in it. So it lends itself to dilating, to becoming dilated. So how do we work this up when patients come to us? We can do a barium esophagram, an endoscopy, and a manometry. The order in which we get these tests really varies on the acuity of what's going on with the patient, but all together we put these tests together to come up with a diagnosis of a scleroderma-like esophagus. I'll just show you some images endoscopically of what we see. So this is a very mild esophagitis, really probably hard to pick out if you don't see this, if you're not looking at esophagus every day like I do, but this is a little bit of an erosion here. So I categorize this as mild. I know that there's some injury in the esophagus, but not a significant amount. And the patient, although this can progress, sometimes patients can just stay like this and we give them anti-reflux therapy to help. This is a really severe case of esophagitis. This is actually a patient of mine who has refractory Candida esophagitis. She's had 7 or 8 years of symptoms, and we haven't been able to really get rid of it. This is the same patient whose upper esophagus was completely normal. So if you can just see the severity in kind of the lower 2/3. And then this is a narrowing in the esophagus. We say that the diameter of the esophagus should be about 15, somewhere between 15 and 20 millimeters. So just about an inch when it's fully expanded. This is an opening that is probably as big as a pencil. So we have to go through and stretch these strictures out. And this happens because of constant acid exposure in the esophagus and constant injury that leads to scar tissue on a superficial level, so not the same kind of fibrosis on the muscular level that we see with scleroderma, but this is on the mucosal level, and we have to go through and basically stretch the esophagus out so patients are able to swallow. Barrett's esophagus, this is what I actually spend the bulk of my time dealing with. Barrett's esophagus is a consequence of constant acid reflux, and we see these in scleroderma patients because they're prone to refluxing. It is a precancerous change that happens in the esophagus, but it is also a protective change. So the esophagus, the cells in the esophagus are squamous cells. So those are the same cells that we have in our mouth, and similar to what we have on our skin. It is not built to deal with acid. So when acid is constantly coming up into the esophagus, some patients, and we don't know why some develop Barrett's and others don't, their esophagus goes through a protective change because of this constant acid exposure. So this change is basically a change in the cells, and these cells are what we call intestinal cells. As you know, and as you can imagine, the intestine is used to acid exposure. Unfortunately, this change is a precancerous change. So what is normal, I think I lost my pointer, but if you'll see there, the whitish tissue is normal esophagus. The salmon-colored mucosa, and sometimes you may read that on your report, salmon-colored mucosa, that is abnormal. So that should not be in the esophagus. When we see that, we have to start to survey them, and that means we have to biopsy these patients. This is the progression of Barrett's. I just want to, patients always come in and they're very scared to hear the word cancer or precancerous, but I just want to point your attention. The progression to cancer with having Barrett's is very, very, very low, 0.1% per year. Once you start to go through this dysplasia change, that's when we intervene with a variety of therapies that we offer at MUSC. We're one of the expert centers for this. So if this happens, we can definitely take care of it, and our ultimate goal is to prevent esophageal adenocarcinoma. So. This sequence, while real, I want to reassure you the progression of it is very small. And so we just watch these patients. We do endoscopies every 3 to 5 years on patients with Barrett's. So what can we do about having acid reflux? I always tell my patients when they are given, when we give them Nexium, Protonix, Prilosec, I'm actually not changing the fact that they're refluxing. I'm just changing the contents of that reflux. And for about 70% of patients, that's great. They feel better, their esophagus doesn't undergo that damage, but there is still a thought, and many of us kind of in the esophageal world believe that even with deacidifying the gastric contents, there is still ongoing damage in the esophagus. So what can we do about it? Well, one of the biggest things we can do is dietary modifications. So my kind of usual spiel to my patients are things to avoid or things to really minimize: fried, spicy, citrus-based, tomato-based products, carbonation, caffeine, chocolate, peppermint. Those are really big triggers for reflux. Just took all the fun out of your life. So I always tell my patients, if I told them never to eat those things, they would look at me and laugh. So minimize, minimize, minimize. And really, most important, I think, more than that, are changing how you eat and when you eat. The biggest thing you can do is not eat 3 hours before you lie down. Okay? Exactly for the reason I told you. The valve is not adequate. So when you lie down, whatever is in your stomach is going to come back into your esophagus. No matter how much Nexium I put you on, it's still going to come back. So I think when you can really try and empty your stomach, that would be great. The other thing to do is elevating the head of the bed. So not just the pillow, because that can sometimes awkwardly just push your neck up, but really a 30-degree incline. There are a couple of devices out in the market that actually incline the head of the bed. Something called Medcline is out there, and those can be very helpful for patients as well. And then, of course, there's the very fancy beds now that are available, but I know they're quite costly. And then the other thing is early PPI use. There's a big group of experts in scleroderma that say once you're diagnosed, maybe it's time to start on a PPI at that point. Again, the debate is out there, right? It changes the acidity, maybe it changes some of the damage, but it doesn't change the stuff from coming into the esophagus. One of the reasons that it's being really advocated is because of interstitial lung disease. So the idea that refluxate gets into the lungs is huge in scleroderma patients. There is a thought that PPIs may remove the noxious acidity, and that could potentially help in ILD patients. This is, all the things that we can do to kind of prevent any sort of additional damage. Management and treatment, so endoscopy, and patients are symptomatic. Sometimes they get really bad esophagitis, and we can help by identifying if there's anything more than just reflux that's causing those symptoms. They may need dilations for those strictures like I showed you. Medications like acid suppression medication, so your PPIs. Prokinetics, so prokinetics are medications that we use to help empty the stomach. They are not great. They have a lot of side effects, so we use them very cautiously in patients. Yeah. Oh, sorry, proton pump inhibitors. Nexium, Protonix. So your trade, you all may have generic names. So it's all of those medications that end in azole, omeprazole, pantoprazole, lansoprazole. So those are the medicines that we give to basically decrease the acid production in the stomach. And then baclofen, which is actually a medication that was really heavily used in GI probably in the early 80s. The advent of proton pump inhibitors came in about 1984, and when they came on the market, all the other anti-reflux measures kind of fell to the wayside. Baclofen, you may know of it as a muscle relaxant, skeletal muscle relaxant, so whenever you pull a muscle, your doctor may give it to you. It has a very fascinating effect on the lower esophageal sphincter. We can't figure out why. But what it does is it actually inhibits the lower esophageal sphincter from relaxing. So in my patients, it's the only drug that I have that actually changes the reflux, right? It actually prevents stuff from coming up. It may or may not work. It can make patients very sleepy. If you've taken it before, it can be a challenge to kind of function. So ideally, we would say the patient could take it 3 times a day, but patients have to work and drive, and so I actually use it more in patients at nighttime to see if we can prevent that lower esophageal sphincter from relaxing multiple times. So, any questions on the esophagus? We'll move on. You guys can save your questions. We can talk. Sorry? We'll go through the stomach now. So what does the stomach do? Well, it's a food reservoir. As you know, it can expand or contract. So patients will often report that they can't eat as much as they used to, especially after an illness. The stomach really has an incredible ability to kind of modify its size to what you are putting in. So it is a food reservoir. It starts the initial phase of digestion. It is a very important part of the immune system, mainly because it produces acid. And then it moves through food through the digestive process. So we count on the stomach to propel food out into the small intestine to start the digestion. The issues that can come up with the stomach, so if you think about kind of the initial thought of injury in the GI tract, it's twofold. Neural damage, so the nerves are damaged throughout the GI tract, and the muscles of the GI tract, which are made primarily of smooth muscle, are stiffened. So as you can imagine, patients can have slowed movement of food out of the stomach. It's what we call gastroparesis. So gastroparesis can affect about 50% of patients with scleroderma. It's a damage of cell signaling, so nerve signaling. The signal to empty the stomach is deficient. The stomach is also a little stiffer, so it doesn't squeeze as well as it does. The signs and symptoms of it include bloating, nausea. Patients say they get full very fast, which we call early satiety, and vomiting. I always ask patients when they come in with kind of these really vague symptoms, I ask them, if I met you 3 months ago, how much would you have been able to eat of a sandwich? And today, how much are you able to eat? So kind of getting an idea of when do they get full? Do they get full faster? And is the stomach just not able to move food so that you get that feeling of satiation or fullness? What do we do about gastroparesis, or how do we diagnose it? This is an image of a gastric emptying scan. Basically, we have patients undergo this test, which shows us how much is moving out of their stomach. You are asked to eat an egg sandwich. Some people love that idea, some people hate that idea. And the eggs are labeled with radio tracers. And what we expect is that by hour 4, so the 4th hour, you basically get an image at onset of ingestion, about 2 hours after, and then 4 hours after. And by the 4th hour, we expect that you will have nothing in your stomach and all the tracer is now in the small bowel. So 4 hours to empty your stomach. We expect at least 10% or less in the stomach. In patients with gastroparesis, they have more than that, and in this case, they're still retained about 40% in their stomach. What can we do about gastroparesis? I tell my patients, and this is not necessarily specific to scleroderma, but just in general with patients with gastroparesis, it's a 50-50 shot with any medicine or any intervention, surgical intervention that we give you. Lifestyle modifications are probably the most important. And if I have a patient who has gastroparesis, I immediately send them to my dietitian. Our dietitians work really hand in hand with us because they are able to sit down with you and go through kind of what foods are going to work and what don't. Before I send anybody to a dietitian, what I tell patients are, I want you to take a 1-week time, and I want you to write everything you're eating and drinking in that week. And that's what I want you to bring to the dietitian, because often patients will walk out of a dietitian's office and say that they didn't get much out of it because all of the things that the nutritionist told them to eat, they don't have in their diet. So I always want it to be relevant to kind of your diet and what's going on in your life. Lifestyle modifications for gastroparesis include small, frequent meals. So instead of eating 2 to 3 meals a day, you're looking at 5 to 6 meals a day. If you were trying to eat a full sandwich at lunch, you're going to try and eat half, and then half about 2 or 3 hours later. And you're going to just graze all through the day. Because at no point should your stomach be so full that you feel like you have to throw up, or that you can't eat anymore, and that movement may take 8 hours. So kind of small trickling foods in. Low residue foods, so things that'll break down easier. Low fiber foods. Fiber takes a long time to break down in the stomach. So those are all the modifications that we ask patients to adhere to. I'm going to move a little bit quickly. We have about 10 or 15 minutes. One of the things that we'll see in the stomach is a cause for iron deficiency anemia. It's called gastric antrovascular ectasia. It's called GAVE. It's actually, sometimes you may hear us refer to it as watermelon stomach. You can see that image there. Those are dilated blood vessels that come up in the stomach, and we see these in patients with scleroderma, affecting up to 20% of patients. We do have management options for it, so first and foremost, make sure that we give you the blood that you lost so that you're not feeling crummy from that aspect. Iron supplementation, because this can cause kind of a slow bleed, so patients can just be chronically iron deficient, and maybe their blood counts don't drop significantly, but it's just small amounts throughout the months. We can also do what's called argon plasma coagulation, so this is a non-contact ablation of the capillaries. And we reserve this for patients who are actively bleeding or who are not responding to transfusions. The small bowel, which is the third most common GI organ affected, usually in the first part of the small intestine called the duodenum. So the small bowel, the main effect of main function of the small bowel is to absorb nutrients. If you think about how much small bowel surface area you have, if we were to stretch out an average adult small bowel, it would occupy 3 football fields. A lot of surface area. The food that moves through it, we say that a normal movement of food through the small intestine is roughly about 6 to 8 hours. So in 6 to 8 hours, it tries to suck up all the nutrients it can. And that can definitely be impaired in patients with scleroderma. There's a loss of smooth muscle, decreased surface area, and decreased movement. So one of the layers of the muscle, we have circular and longitudinal layers, they start to contract. That basically shrinks the amount of surface area we have to have some absorption, and patients end up having also slowed movement of food through their GI tract. This is a normal small intestine. This is of a patient with scleroderma. You can see these little, almost like fan-like images, and that's where what we refer to as house drawer, the small intestine, is really contracting, and we've lost some surface area there. One of the things that patients can present with is a bowel obstruction, so what we call a pseudo-obstruction. Not a true obstruction with something there, but just kind of a stunned gut or a slowed gut. This can be very problematic because patients can present with bloating, nausea, vomiting. They can't tolerate oral intake. Sometimes this is hours after they eat when it hits the small intestine, and then they start to throw up. In severe forms, it can cause bowel perforations. I have not seen that in my 10 years, but it's definitely reported. We can diagnose this with imaging. This is a very dilated loops of bowel, so just an x-ray can be very helpful. And treatment, sometimes we'll have patients have an NG tube, so they may have to be admitted for this. And then we can help things along by using some medications. And I can't impress enough the importance of movement. So moving your body in general does an incredible amount for the GI tract. From standing up and allowing food to pass through the esophagus to kind of just walking is really, really good for the GI tract. So those are going to always be my first recommendations for patients, especially if they're leaning towards being more sedentary. Small bowel malabsorption, we'll go through this rather quickly, but this is a really important area because this is where malnutrition can really occur. So in malabsorption, you basically can have slow movement, bacterial overgrowth, and that can cause diarrhea and bloating. Those are the main symptoms of bacterial overgrowth. What happens in bacterial overgrowth is patients can have symptoms of bloating, nausea, vomiting, diarrhea. Steatorrhea is a fancy way of saying fat absorption or fat loss in the stools, and weight loss. We have a number of tests available, and you may hear GI doctors talk about breath tests. If I get a good enough history from a patient, and this is what I think was happening with the first patient I talked with you about, the 75-year-old with chronic diarrhea, I usually will just start him on therapy. Sometimes by the time we get all of this testing done, the patient could have been treated. And what do we do about it? Well, bacterial overgrowth is basically bad bacteria that kind of overgrow the good bacteria, and that happens with just food sitting there for a long time. There are a variety of ways. The first way that we try to treat it is by a short course of antibiotics, anywhere from 10 to 21 days. If a patient relapses, meaning their symptoms come back, and it keeps coming back, then these may be patients who may need what we call a rotating antibiotic schedule, where they are placed on 4 of these antibiotics 10 days of the first month, 4 consecutive months where we switch, and then we give them a little bit of a break, and then we restart again. It's not ideal. We don't like putting patients on antibiotics because it builds resistance, but sometimes it's the only way to keep things from worsening. And what we want to prevent in this case is really malabsorption. So malabsorption in patients, or malnutrition in patients, has a really high 10-year mortality. These are the patients that we worry about, and these are the patients where if we act earlier, we could prevent death and severe illness. In these patients, how do we figure out if somebody's at risk for malnutrition? So we have a couple of different blood tests that we check, but this is a questionnaire from the Canadian Scleroderma research group, and these are questions that patients would ask. And I think in many patients, and this is something I haven't implemented yet, but may start to implement, is potentially doing this on an annual basis to see if and when patients are at risk for malnutrition. We start to worry about malnutrition when there's weight loss of greater than 10% in 1 year or greater than 5% in 3 months. Those are all indications to us that malnutrition may be something that we are concerned about. Some of you may have questions about the role of probiotics in malabsorption. My feeling on probiotics are, except in patients who are on chemotherapy, which the use of them can be very controversial and sometimes a little bit harmful. For the most part, they can be very helpful. If I'm treating somebody who is having bacterial overgrowth, I always put them on a probiotic along with the antibiotic, just to help the GI tract cultivate good bacteria. If patients always ask me, do you have one that you prefer? I don't. What I always stress to them is the more strains of bacteria in a probiotic, the better. Okay, so don't buy those that have just one strain. And then your pharmacist is really probably the most helpful, as they'll be able to tell you. Patients always come back and report to them what worked and what didn't work, so they're a really good resource for them. In just the last few minutes, again, the lower GI tract, really the same pathology. So slow transit leads to constipation. The anorectum, which is the second most affected organ, the sphincter of the anorectum can be really compromised, and patients can get fecal incontinence, so not able to kind of control your bowel movements. And then we have all these different possible sequelae from constipation. The colon, about 3 to 4 feet long, so it has this whole time to kind of create feces, exchange water, and then excrete the feces. Signs and symptoms of problems with the GI tract include constipation, diarrhea, fecal incontinence. Impaired motility is really the big cause here, and then an impaired sphincter function. The workup for it, we usually try to see, well, how long does it take things to actually move? If you see these little markers here, this is called a 6-marker test, and what happens is patients ingest these markers, and we take an image at 1 day, and then we take an image at 7 days, and what we hope is that things have moved along and have been excreted. In some patients at 7 days, sometimes you'll see the 6 markers still over here. That can be very impaired motility. But even at 7 days, having them here shows us that things are moving very slowly through the colon. Water as treatment and management. This is the first thing I always tell patients. In any adult, the most common cause of constipation is lack of water intake. Anybody want to take a guess of how much water you should be drinking?
Gallons.
So at least 8 glasses of water in patients with scleroderma. I tell them to push it to close to 100 ounces, 80 to 100 ounces. So that's about 12 glasses of water a day. That's like a job. So I tell you, what I tell my patients is instead of sipping on it all day, because a small bottle can last all day when you sip, just take a big, couple of big gulps. Stool softeners. Fiber is very controversial. As I talked with you about, it can really worsen gastroparesis, so it's a little tricky to recommend it, and then we have some prescription medications as well. We'll end with the anal rectum, so again, the real muscle here allowing us to kind of hold our stools and defecate when we are supposed to. It is the second most affected area. The effect on it is very similar to the lower esophageal sphincter. It's weakened, and so it can really cause a lot of psychosocial effects. Patients can have anxiety, depression, fear of public spaces because they don't want to soil themselves, or they're worried about where will they go to the bathroom. This is just an image of the internal anal sphincter, which is this dark area here. When you look at it in this one, it's completely atrophied, so you hardly can see it, and you see a lot of deposition of kind of fibrin and tissue there that doesn't allow it to function. I'll move through this rather quickly. So management strategies here, something to just point your attention to: sacral neuromodulation, biofeedback therapy. These are 2 things that we offer to our patients who have what we call dysernergic defecation, so problems with kind of moving their bowels. If patients present to me with these issues, I'll usually send them over to our colorectal surgeons, who are very good at kind of picking out if it is the sphincter that is at risk, and they will have options such as neuromodulation therapy. Positional therapy, so have you guys heard of the squatty potty? Yeah, so really helpful, can definitely be tried, and something that I think patients have had a really good response with. So this is just a summary of what we went through. This is also in your slide packet, so kind of how patients present, what treatments we have available. There is, we have a long way to go as far as helping patients with scleroderma, but I think earlier assessments are key. So as patients get diagnosed, kind of keeping an eye on their symptoms that they may not even report as symptoms, but we may be able to pick up with our questionnaires. And this is a standardized questionnaire that you can reach, and again, this web address is on your handout. That can be very helpful. Knowledge is power, so part of my, one of my take-home points today is just knowing that some of the symptoms you might be dealing with, we may have treatment strategies for it, and that could be really helpful to you. And then our role in this spectrum is educate, 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 try and give you some preventative measures, try and assess your symptoms before you even report them to us. And just to summarize, scleroderma can affect any part of the GI tract. The severity can vary to mild to very severe. The esophagus is the most common organ affected. Preventative measures are available. I wish there was more treatment, but hopefully we get there in the next decade. Accurate and timely diagnosis to prevent severity of symptoms, especially when it comes to malnutrition. And multidisciplinary approach for patients is probably going to be the best to serve them. So GI doctors, nutritionists, your rheumatologists, all of us working together. And the treatment will vary from patient to patient. So you may talk to the person next to you and they're on a slew of different medicines and treatment modalities, and that'll be very different to you based on how you're presenting. All right, thank you so much.